So really, I want to sort of draw to a conclusion. Really, what are the recommendations that we came to? So we started with some general principles. So first of all, we acknowledge that ultrasound medicine is now an integral part of our ICU care. We recognize that clinicians and organizations both have responsibilities to minimize infection transmission. Doctors, if they're using ultrasound equipment, need to be familiar with the equipment, and that includes the infection control policies related to that. And we also, recognize that there is a lack of research and a need for research to improve infection control. Specifically, our recommendations are as follows: the use of single sachet sterile gel only, the use of high-quality sterile probes during invasive procedures, cleaning as a mandatory first step preceding all disinfection processes. In terms of choosing the level of disinfection between high or low level, we've really gone with the ASMA-CIPSI guidelines with a few small exceptions as follows. That it's important to clean the machine as well as the probe, that high-level disinfection should be used over low-level disinfection following ultrasound-guided procedures. And we are consistent with the ASM guidelines with mandating that documentation is necessary after high-level and preferable after low-level disinfection. And finally, probably the most important recommendation is that dedicated trained staff, non-medical staff, should be tasked with performance of ultrasound disinfection. We did produce a chart to assist with what you need to do in various situations. And really that concludes my talk. I think ultrasound medicine has added greatly to the care of ICU patients, but we need to minimize the risks associated with that. And with that, I'm going to open up the discussion to some questions if you have any. Thanks very much for the opportunity to speak with all of you. I really appreciate it.
Thank you so much, Dr. Castello. So we're now going to begin answering any questions that the attendees have submitted regarding the presentation. As a reminder to all the attendees out there, you can still submit text questions through the question pane of the control panel. With that, Dr. Castello, our first question here, let me just get this pulled up. How do you manage a quick turnaround time in disinfecting probes between patients?
So, as I say, when we were choosing what equipment or not necessarily equipment, but what products to use, I think turnaround time was very important to us. We can really turn around a machine within 2 to 3 minutes, just by the nature of the product. Now, one has to be careful when reading the literature provided by manufacturers, because they'll talk about cycle times for machines, they'll talk about drying times for chemicals, but this is not the time that requires you to do a clean, to remove the debris, to then apply the disinfectant. You then have to let it dry. But really, the turnaround time can be as short as 2 or 3 minutes if you choose the right products. So really, the way we did it is we chose the products, and it was a really big consideration in what products and devices that we chose in our department. And that's how we did it. I mean, we do have multiple machines, but irrespective, I think moving equipment down to SSD departments for high-level disinfection, I mean, that might be okay with a tow probe, but if you're a cardiovascular surgery center, you're going to need rapid turnaround on that time so that, two people can get sick at once. It does happen. Choose your products wisely.
Thank you. So our next question, what discipline do you propose the non-medical staff reprocessing probes at point of care should be?
Yeah, so I think so most intensive care units within Australia do have equipment officers who are tasked, who clean they clean the ventilators, they do that. I think at night, there are often senior nursing staff available that are looking after, if you use a CMAC blade, there really is no reason that they could not be tasked with doing that. Now, in smaller centers, I do fully recognize that, it's reasonable and it's possible that doctors can perform some of these tasks, but a couple of things have to be put in place for that. Number one, I think the doctor, if he has other clinical priorities, should not be expected to do that. And number two, the doctors need to be trained to do that. And that is actually quite an extensive barrier. So I think it's going to be a combination of equipment officers, senior nursing staff, and also the SSD departments. But I'd like to just maybe segue into, I think probably the real answer that I would like to see happen is, I think that infection control and the tasking of doctors is really based on a false premise of ultrasound being, somebody's hobby. It's not recognized as just being core ICU practice. And there's some serious under-resourcing of core infrastructure as a consequence. The best way to deal with this would be if intensive care departments had dedicated sonographers. If they had dedicated sonographers, they could clean the equipment, they could maintain the archive, they could be doing the quality control, they could be assisting with teaching, and they could be assisting with providing the clinical service. I think a huge burden is placed on practitioners who provide ultrasound services and echocardiography services to intensive care. So the ideal answer I would like to see is sonographers dedicated within ICUs. And I think this, I know this is a big change in practice and it's going to cost money. But for most units, and I think of the medium to large size units, this is completely feasible. For the smaller units, that perhaps is not going to be possible. But that's really what I would like to see happen.
Great, thank you. So this next one starts out with a thank you for your wonderful talk. What is the definition of intact infected skin? We have a lot of pushback in this requirement.
Gosh, I don't know if there's a specific definition, but I mean, to me, it's just clean, healthy skin, where there's no rashes, there's no breaks in the skin, no skin tears, no wounds. But I think another important component is that it's not contaminated by body fluid in addition. Having considered my own practice, I reckon about 40% of the cleans that I do are high level and about 60% are low level. Now, I do a lot of scanning. What if you didn't do a lot of scanning? I suspect that ratio might go up if a lot of what you're using ultrasound for is for vascular device replacement. But if it's infected, broken, things like shingles, or as I say, contaminated with body fluid. In many ways, it's a difficult definition. I think it's a good question because you can never be sure, and one could argue that high-level disinfection would be appropriate, but if you want to completely eliminate the risk.
Okay. So this one, just a comment here, the recommendations are closely aligned with the findings of the UK Committee on Reprocessing of RMDs. And they also have a question, are you expecting an instrument-grade disinfectant to be used on the high-frequency portion of the machine, or is a hospital-grade Sporcidal being recommended?
So if a device is not a reusable medical device, you can use a lower grade of disinfectant. The issue, I think there's two things to consider there. One, how many different products do you want to maintain in your inventory? And two, what is the impact of these disinfectants on the high frequency touch areas? Will they degrade your machine? Now, most manufacturers provide advice as to what products are safe to use on their probes, but very few, if any, provide advice as to what products are safe to use on the machine. If we're talking about touchscreen machines, then it's almost certain that non-instrument grade disinfectants can be used on these machines without any serious consequence. But for a lot of us using trackballs and keyboards, almost certainly all products will degrade the machine to some extent, and I think therefore instrument grade disinfectants are less likely to cause harm. So what I use in my own practice is we just use the same instrument grade on the rest of the machine. And I recognize that over the long haul it probably will cause damage to my machine, but that's just a cost that we have to accept. Within the guidelines, we have recommended the push towards touchscreen only. I see it as the only viable long-term option within intensive care practice. But it is a dilemma. You certainly are free to use hospital grade, but will that be more damaging to the machine? The other thing to consider is the residual product that you're going to be touching. Certainly with high-level disinfectants, depending on how they are used, there is a little bit more nuance than the binary decision than what I've said. One does have to choose between high-level and low-level. But for example, if you were using a high-level disinfectant on a toe probe, and it's going to touch a mucous membrane, that does need to be cleaned off with sterile water. So, and then some products provide that, other products don't. So some high-level disinfectants are registered for toe use and some are not registered for toe use. Really what we do, as I say, is we use our high or low level disinfectants on the other parts of our machine, and we just wipe it off, sometimes with an alcohol wipe if residue builds up, or with just water.
Thank you. So our next question, do you include bladder scanners and Dopplers in these recommendations?
I would like to, but getting my department to use them is another issue. But again, you know, they are machines that move from patient to patient and touch the patient. So yes, they should be cleaned. They are reusable medical devices. They absolutely fit into this.
Okay. Will this publication be adopted as the professional guidelines by CIMC?
So it was
CITM.
Sorry, the College of Intensive Care. So has it been endorsed, I think is the question. So the document went to the board really in, I can't remember now, maybe about late February, in the middle of the COVID crisis. It was presented to the board and it was broadly accepted. Just given the madness that was going on at the time, it wasn't formally endorsed. That may or may not happen. I hope it happens, and in fact, one of the recommendations that we did ask for was that standards for infection control become basically college standards for accreditation. And I think this is important. The standards are written really with a view, one, to provide some guidance, but really, and we made this very clear, that the standards, the document that we've produced is also written for our administrators. I think mandatory standards, you know, make it so much easier for doctors to get funding for this equipment. So one, the document as presented has been reviewed and broadly accepted by the Board of the College of Intensive Care, and we have asked that these standards become accreditation standards for college accreditation purposes. Whether that happens, I don't know.
Okay, thank you. We use Tegaderm as our probe cover to reduce cleaning and HLD or LLD after use based on procedure. This ensures we have a quick turnaround time. What do you use?
We use sterile probe covers, yeah. So we don't recommend them. I mean, they provide an inconsistent barrier. I mean, they do probably minimize soiling, and they do, you know, they're not doing nothing, and they probably do increase efficiency with disinfection cleans. I think as long as you're doing a good disinfection afterwards, that's more important. But just don't overestimate the benefit that you're getting from a sterile cover. The sterile covers they're actually quite expensive. You know, our covers cost between $5 and $7. And when you compare that with a $2 to $3 cost of high or low level disinfection, you know, they are quite expensive. And again, I think we worry about the cost of disinfection way out of proportion to the other money that we spend on infection control, including on sterile probe covers. For example, you know, an inline suction catheter costs about $22. If a patient goes into a room and then the patient is changed, we're spending $800–900 just on disposables. If that patient changes, we throw out $800–900 worth of stock. We're spending vast amounts of money elsewhere on infection control and practically nothing on ultrasound.
Thank you. This next question, Westerway and Basil found the cable of the probes to be highly contaminated. Does the group recommend products that are only capable of disinfecting the entire device to the correct level, not just the handle and probe distal end?
No, it includes cables as well. I didn't include in my talk, but we absolutely include cables. The thing is that we can never get full clearance as to, if the cables wear out and they become contaminated, they'll simply just have to be replaced. But yes, no, anything that's high frequency, that would include cables, of course.
Okay, Dr. Castello, thank you so much. That looks like that is all of the questions that we have for the presentation today. On behalf of Germatech, who sponsored the webinar, we'd like to thank you for taking the time to join our session. Thank you and enjoy the rest of your day.